Welcome to Medical Microbiology. This is Introduction 2. We are going to see the strains, normal flora, pathogenesis, and collection and handling of the clinical specimens. So the gram stain has like four type of procedures. Like we will be using crystal violet, that is the primary stain, the iodine, that is the mordant, the decolorizer removes unbound dye. It will be mostly acetone or alcohol, and the saffron O, that is a counter stain. The results of gram stain. So the gram-positive bacteria will stain purple, that retains the crystal violet. The gram-negative bacteria will retain the red or pink color, that is, it takes up the saffronin. The clinical use of this gram stain results will be rapid preservative ID, internal control, and the gram stain usually show the WBCs as pink, so they stain pink. So there are some special stains like acridine orange, methylene blue, acid phosphate, Auramine-Rhodamine, and Calcofluor White. We can see the uses. Acridine orange stain is a fluorescent orange stain for finding small numbers of bacteria, especially in body fluids like blood or spinal fluid. It works even when there is a lot of debris. It can detect both live and dead bacteria. So the procedure will be you have to stain the smear for 2 minutes, wash it, and view under a fluorescent microscope. Methylene blue. This is helpful for demonstrating like metachromatic granules and characteristics morphology of Corynebacterium diphtheriae. And this is like the Corynebacterium diphtheriae, which is isolated from loafer coagulated serum medium. So the procedure is simple. You have to stain, wash, and observe. Acid fast stain. Acid fast stain we use especially for the tough bacteria like Mycobacterium, Nocardia, and Actinomyces, which have a waxy lipid cell walls. They don't decolorize easily. After you stain with acid fast, they don't decolorize easily, even with the acid alcohol. Acid fast bacteria appear red on a blue background, and the primary stain will be carbofusin. And there are two types of acid fast stain, that is quinone stain. So this is stained without any heat, but Ziehl-Neelsen stain uses heat to get the stain in. Auramine-Rhodamine stain, the fluorescent stain that lights up acid fast bacteria like TB, that is the tuberculosis bacteria, and the cells appear yellow against a dark background. It is fast, a sensitive method, stained with Auramine-Rhodamine and decolorized with acid alcohol, then flooded with potassium permanganate, observed using a fluorescent microscope. Calcofluor White stain. It is especially for the fungus, and it binds to chitin in fungal cells walls, and it is great for spotting yeast and fungal hyphae in skin scrapings and the tissue. Under the microscope, the fungi glow green or blue white under the UV light. Now we are going to see the normal flora, the microorganisms that is always found in our bodies and like healthy persons. So the general characteristics of this normal flora will be they are local conditions suited for the growth in a particular area, or resident flora colonized for months or years. The transient flora are present at a site temporarily. And there are parasites. These are the organisms that live at the expense of the host, and the symbionts are the organisms that benefit the host. And the commensals have a neutral effect on the host. And the carriers, they harbor the organism without manifesting any symptoms, but is capable of transmitting infection. It is known as like a carrier state. That is like the person will be carrying the microorganisms without any symptoms but capable of transmitting infection. It may be a human or like an insect or animals. The opportunities, these organisms that do not normally cause infection but can do so if the condition of the host changes, especially like immunosuppression. If the host is like immunosuppressant or on like cancer or immunosuppressant drugs, they may have like opportunistic organisms that are like not in the normal flora. They become opportunistic and give diseases. Let us see the normal flora of the skin. The skin contains a wide variety of microorganisms that are not eliminated by washing or superficial antisepsis. So, for example, Propionibacterium acnes that colonizes the sebaceous glands, the Micrococcus, Staphylococcus species, and diphtheroids are common. These are on the skin. The intact skin is an effective barrier to microbial invasion. Normal flora of the mouth. The mouth contains large number of bacteria, mostly that is commonly the Streptococcus species, especially the virulent species, the Coagulase negative Staphylococcus, the Peptostreptococcus, and other anaerobes. So the normal flora of the respiratory tract, those are like beyond the oropharynx is normally sterile, and in the oropharynx it mirrors that of the mouth. The ciliary action of the epithelial cells and the mucous movement remove invading organisms. The nose and the nasopharynx contain Staphylococcus aureus and Staphylococcus epidermis and the Streptococcus species. Community outbreaks of infection that are common are the Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitidis. Now come the normal flora of the gastrointestinal tract. Most organisms, like microorganisms, are destroyed in the stomach due to the acidic pH. The survivors multiply in the colon. More than like 90% of the microbial population is comprised of anaerobes. Alteration of the normal flora by antibiotic may allow a superinfection by Clostridium difficile, that is a necrotizing enterocolitis, the Candida albicans, or Staphylococcus aureus. This Clostridium infection mostly happen in like the hospitals where the patients get like a lot of antibiotics, and that may end up in necrotizing enterocolitis, and the same with the Candida albicans and Staphylococcus aureus. The normal flora of the gastrointestinal tract, still they are like common organisms like Bacteroides species and the Clostridium species, Eubacterium species, the anaerobic Streptococci, Enterococcus species, and Enterobacteriaceae. The genital urinary tract has the formal, they are like colonized by the skin organisms, like the outer segment of the urethra is colonized by the skin organisms, and the vagina is colonized with lactobacillus, anaerobic gram-negative rod-shaped bacteria, and gram-positive cocci. Now, the pathogenesis of infection. The host resistance by two types of immunity. One is innate, and the other one is acquired. The innate immunity is like known as like natural immunity, is a non-specific mechanism of the resistance to disease. The acquired or the specific immunity develops in response to a specific foreign antigen, that is like a bacterium or a pathogen, and it is like very active response to the immunization or disease, and it is passive through placental transfer or infusions of serum or plasma. So the innate immunity has like physical barriers such as skin, mucous membrane, and cilia. The cleansing action of the fluid in the eyes, respiratory, digestive, urinary, and other genital tracts are useful in innate immunity. The antimicrobial substances such as secretory IgA, lysozyme, B lysins, and interferon are produced in the human host, and they helps in innate immunity. The indigenous microbial flora and inhibitory bacteriogens, they help in the innate immunity too. And the phagocytosis, inflammation, and complement activation are also important non-specific defense mechanism of the innate immunity. Acquired immunity. The humoral response involves antibody production by the B lymphocytes or the B cells. The cell mediated immunity involves cells such as macrophages, cytokines, and the T lymphocytes. The cellular response provides immunity against intracellular pathogens, including viruses, fungi, and mycobacteria. Okay, now the criteria for a successful pathogen. The degree of pathogenicity of a microorganism is directly related to its virulence. A virulent strain is characterized by its ability to evade and overcome host defense and cause disease. The microbial virulence factors include adhesions, capsular polysaccharides, and production of extracellular toxins and enzymes that may cause damage to the host. And there will be an appropriate portal of entry which is necessary for the successful transmission of a disease. For example, respiratory pathogens enter the respiratory tract via inhalation of aerosolized respiratory secretions, and gastrointestinal pathogens enter the GI tract via the ingestion of contaminated food and water. A effective, ineffect, a sufficient, ineffective, effective A sufficient infective dose is needed for the microorganisms to be able to cause disease in this host. Some organisms can establish an infection with a relatively low infective dose, for example, Shigella, whereas others require much higher infective dose to cause disease, example, Salmonella. Now we can see the transmissions, the types of transmissions. The airborne transmission, it is through the aerolized respiratory secretions like sneezing or sometimes coughing or contact with the contaminate inanimate objects of fingers and hands sometimes. And then the fecal oral route or ingestion of contaminated food and water is a means of transmission for gastrointestinal infections. Sexual transmission caused by the infection, like it is a cause for the venereal disease, and some diseases can be transmitted by like skin to skin or via direct transfer of saliva, example kissing. So sexual transmission is like through like sexual contact, and the animal and the human bites they can cause serious wound infections. They can be caused by the mouth flora, for example rabies. It's a viral infection transmitted from an animal bite. Opportunistic pathogens, this is like environmental bacteria that can enter the human via cuts or wounds, like trauma wounds. Arthropod vectors like ticks, fleas, mites, they transmit diseases like malaria, Lyme disease, plague, Rocky Mountain spotted fever, hemorrhagic fever. The infection agent multiplies in the arthropod and is transmitted when the arthropod feeds off a human host. Zoonoses. Zoonoses are the diseases of the animals that are transmitted to humans. So the transmission is usually via contact with infected animals, animal secretions, and animal products. Zoonoses can be transmitted via animal bites or arthropod vectors. Now we can see the collection and the handling of the clinical specimens. So the collection, it must be a properly collected specimen for our quality diagnostic information and patient care. And there must be safety while collecting the specimen. So the universal precautions throughout the collection and the handling process must be maintained. So the tech have to wear a gloves and laboratory coat while collecting or handling the specimen, and eye protection is necessary to avoid any splashing because it causes like potential hazard. You have to just wear eyeglasses or goggles, and accidents or injuries must be reported immediately to the lab supervisor. So the general guidelines for collection of specimens must be the specimen should be from the infection site and not contaminated by the surrounding area. For example, culture within a wound, you have to take it from the wound, not from the surface or the surrounding skin. And the collection before antimicrobials are administered, for example, if the patient is given antibiotic in a certain time, the collection must be done before they are taking the antibiotics. And the appropriate sterile containers like collection devices containers must be used and aseptic technique must be required. And the specimen containers should be always labeled with the patient's identification, that is like the name, date of birth, and if there is like a hospital ID, outpatient number, whatever, and the date and the time of collection and the source of the specimen. So collection from various body parts like the throat. The tongue should be like depressed before swabbing between the tonsillar pillars and behind the uvula. And the cheek, the tongue, and the teeth should not be touched. And for nasopharynx, a flexible wire nasopharyngeal swab should be gently inserted through the nose into the posterior nasopharynx, rotated, and then removed. Sputum, whenever possible, the patients should gargle with water, not mouthwash, immediately before sampling. Early morning specimens are best, and the expectorated specimens from a deep cough should be collected into a sterile specimen cup. Stool. The stool must be collected in a clean, wide-mouthed container with a tight-fitting lid. If not, be plated within an hour of collection. It should be mixed with a transport medium, example like buffered glycerol, saline, or carried blade transport medium. The change in the pH and temperature over time is detrimental to some species like Sigilla, and it should not be contaminated with urine. So the stool must be like separated. There must not be any urine. And the preservatives in the container. There are like some containers with preservatives that are used for bacterial culture and the oven parasite examination. So the urine collection, the midstream clean catch is the most important, like the common collection method. And the proper cleansing of the urethral area in women is very important. The first few millimeters, like the first urine is voided, that is flush out the urethra, discarded. And the specimen should be collected into a sterile specimen cup and transported immediately to the laboratory or refrigerated because contaminants grow readily at room temperature. The cultures of catheterized urine specimens usually have less contaminating bacterial flora. Collection of blood. So, two or three cultures should be collected at random times during a 24-hour collection. Collecting more than three sets of cultures in a 24 period does not significantly increase the probability of detecting bacteremia. And the skin before collection of the blood, it must be disinfected with 70% alcohol followed by iodine, and the disinfectant is allowed to dry. The puncture site should not be palpated after the disinfection. Ideally 20 to 30 ml of blood per culture is collected from an adult, and if it is an infant or small children it will be like 1 to 5 milliliter up to their body weight. The iodine should be cleaned from the puncture site with the alcohol following the venipuncture procedure also. The cerebrospinal fluid is collected aseptically by the physician. So this specimen should be processed immediately and not exposed to heat or refrigeration. The abscess aspirates or exudates like sometimes like synovial, pericardial or chest fluid should be collected by the physician with a needle and syringe. The use of swabs may inhibit growth of anaerobes or increase the likelihood of contamination with indigenous bacteria flora from adjacent tissues. Example like mucous membranes or superficial skin surfaces. So care should be taken not to inject any air bubble into the syringe for anaerobic samples. So, collection of specimens from genital tract. For men, the exudates may be expressed from the urethral orifice, or a small diameter swab may be inserted 2 to 4 centimeter. I'm sorry, it's 3 to 4 centimeter into the urethra. And the specimen should be plated immediately on the appropriate media, not allowed to dry or to be exposed to cold temperatures. A direct gram strain smear should be prepared. So the genital urinary tract specimen from women is like from the cervical specimens that is obtained by the physician with the aid of a speculum. So the lubricants may be lethal to Neisseria gonorrhea, so they must not be used during the by inserting the speculum. And the cervical mucus plug is removed and a sterile swab is inserted into the cervix, rotated and strained, like allowed to remain for a few seconds. The specimen should be plated immediately to the appropriate media and swab should not be refrigerated, as refrigeration may be lethal to genital pathogens, and a smear of the gram stain should be prepared from the specimen. So after the collection, it's necessary like we need to know how to handle the specimens and transport it. So transport all specimens to the laboratory promptly. Anaerobic specimens must be transported in an anaerobic transport system. If transport cannot occur immediately, most specimens can be held at 2 to 8 degrees Celsius. Exceptions to this include include specimens that likely contain temperature sensitive organisms, example Neisseria, and the blood culture bottles and the CSF. Swabs are the least collection, like desirable collection and transport method. It's because like organisms can be successfully cultured if the swab is handled and transported properly. If not, it will be drying out. The swabs are inappropriate for culturing anaerobes, although in some clinical settings they use culturates. So, if swabs are used for the culture of anaerobes, it's essential that an anaerobic culturate should be used. Aerobic culturate will be rejected for this kind of specimen. Processing. So, the processing in the lab, we have some media selection. So most of the labs, that is the isolation protocol, will be the blood agar with 5% sheep RBC and the chocolate agar for first TDS isolates and the specialized media, example mannitol salt agar or bismuth sulfate agar, camelobacter agar, thiosulfate citrate bile salts, sucrose, like the TCBS agar, when specified organisms were suspected. Substitutions with acceptable reasons, like substitutional media, are used, like McConkey agar in place of eosin methylene blue agar. And then the pre-reduced anaerobically sterilized cultured media, that is PRAS, is used for culture of anaerobes. Incubation. The normal incubation temperature for our bacterial cultures is 35 degrees Celsius to 37 degrees Celsius. The culture plates may be incubated in ambient air, but the incubation in an caphenophilic atmospheric of 5% to 10% carbon dioxide is recommended to enhance the growth of fastidious bacterial isolates. Anaerobic cultures are anaerobically like cultured at like 35 degree to 37 degree. It's incubated at 35 to 37 degree. And then anaerobic bags, jars, or anaerobic chambers are appropriate for incubation for anaerobic cultures. The recommended incubation temperature for stool cultures for isolation of Camelobacter jejuni is in microphilic, capnophilic atmosphere at 42 degree to 45 degree. So there are like specimen rejection criteria. This varies from lab to lab, but there are like common things like you can just focus here. The rejection criteria should be a part of your written policy of every clinical laboratory. The processing and the culture of inappropriate specimens lead to increased cost of misinformation. In the event of a specimen is rejected, the person submitting the record should be contacted and informed. So, in some cases, the difficulty of collection makes culturing necessary, although the results are not optimal. For example, like CSF and some other body fluids, like synovial fluids or like acetic fluid. So these are like examples of like specimens which are like rejected. So there are like a comprehensive list, but still I just put like a small list here. So they just 24-hour urine or sputum collections for culture. They are mostly rejected because they cannot be done for like culture. And the specimens received in a non-sterile or contaminated containers, including those in which the specimens have leaked out. So leaked specimens, they are like contaminated and they are rejected. The specimens contaminated with barium or other foreign substance, like for example, if they give like a barium enema, something, the stool specimens are like contaminated, so it is rejected for that. The culturing of Foley catheter tips and the saliva instead of sputum. So this one is like not like the sure like specimen rejection criteria, but still you have to follow your lab policy, and there are like the 24-hour urine for culture is like rejected, and the specimens with a different patient ID, or if there is like a confusion in the labeling, it's rejected because you cannot give a bad report. Unrefrigerated urine specimens like 2 hours or more post collection, they are rejected. And the anaerobic culturing of midstream urine, upper respiratory